Good morning or afternoon, everyone, and welcome to this webinar. I'm Mary Naylor, and along with Mark Pauley from the Wharton School, I've had the great honor to direct the Interdisciplinary Nursing Quality Research Initiative, or INQRI program, along with Lori Melikar, Senior Program Officer at the Robert Wood Johnson Foundation, and Heather Kelly, a Program Associate. I think many of you have been in touch with Heather over the years, and certainly with respect to getting this webinar going. So really, we're very excited to welcome you to the first in a series of webinars that are designed to share with you what teams have learned about the dissemination and implementation of evidence-based approaches that are designed to improve the care delivered by nurses individually or as members of the team, and especially to have a major impact on patient and family and community outcomes. INQRI is sponsored by the Robert Wood Johnson Foundation, and we want to thank our terrific colleagues at RWJF for the tremendous leadership and support and guidance that they have provided since the program was conceived, to all of us on the leadership team and to our grantees over the years. Starting in 2006, the first round of INQRI-funded interdisciplinary teams began to conduct research studies, and areas that we focused on in calls for proposals beginning at that time were trying to figure out how we would produce measures that capture nurses' contribution to quality. Over the years, then, what are the processes that are used by nurses that could improve these outcomes that are so important to patients and families? All of our work has attempted to coincide with a national healthcare agenda to deliver high-quality patient care. So in our third year, we focused on the role of nurses on healthcare teams and the work and impact of their work on improving efficiency and value. This last solicitation, which occurred in 2010, we sought to kind of live out our mission, which was to generate, disseminate, and translate knowledge into practice. And this last group of grantees took a look at what existed in terms of evidence-based approaches and conducted efforts to rigorously translate evidence-based practices into a wide range of environments. And you're going to hear from one of these grantee teams today. I think Heather has put up on the slide all of the future webinars that you'll see, so we would encourage your participation going forward, and you can hear more details or read more details about these sessions on our INQRI site, www.inqri.org. So at this point, I want to personally acknowledge the unbelievable support and guidance that we received from a select group of individuals, stakeholders. We actually reached out to a broad range of stakeholders, potential end users of our science throughout the work, but there was a national advisory committee that has guided us through our many program developments. They have both contributed to the design of the program, reviewed proposals, advised grantees on plans, led discussions at our annual meetings, and have been an integral part of all of our efforts. And I know I can see on my list here that we have two representatives, Randy Krakauer and Shelley White-Means, two distinguished representatives from our National Advisory Committee joining. If there are others, welcome to you as well. What I'd like to do now is introduce you to one of those individuals, Shelley White-Means, who will introduce you to the project team. Shelley is a professor and director of the Consortium for Health Education, Economic Empowerment, and Research at the University of Tennessee Health Science Center. She is a distinguished health service researcher. Her research emphasizes social determinants of health disparities, racial ethnic disparities faced by Blacks and Hispanics in the utilization of medical services, and labor market implications and costs of family caregiving. Really both of these areas such important foci for us as a society. Her recent studies have documented the distinction between racial ethnic differences and racial ethnic disparities in healthcare utilization, and also how labor market disparities are associated with health insurance disparities. Most importantly, from my perspective, in addition to the wealth of expertise she brings, she's been an incredibly active member of our National Advisory Committee since its inception. And I thank you personally and on behalf of our team, Shelley, for your service and for leading our session today. And Shelley, now I'll turn it over to you.
Thank you, Mary. It is my pleasure to introduce our INQRI Cohort 5 presentation today that is led by Robin Newhouse. The team considers a priority public health issue, improving screening and treatment for substance abuse. The challenge that they address is finding cost-effective and efficacious strategies to screen and provide treatment for persons who have excessive use of alcohol, drugs, and tobacco. They identify the characteristics of hospitals and nursing that are associated with improvements in the use of the screening, brief intervention, and referral to treatment tool. And our presenter on today is Robin Newhouse.
Thank you, Shelley. First, I'd like to introduce you to our team. I'm Robin Newhouse. The co-investigator for this study was Dr. Bonnie Spring. Bonnie is a professor of preventative medicine, psychology, and psychiatry, and behavioral scientist, and director of behavioral medicine at Northwestern University School of Medicine. She's also past president of the Society of Behavioral Medicine and founding editor of Translational Behavioral Medicine, Practice, Policy, and Research. Dr. Jason Satterfield is professor of clinical medicine and director of behavioral medicine in the Division of General Internal Medicine at the University of California, San Francisco. Dr. Satterfield directs the Social and Behavioral Science curriculum for UCSF School of Medicine and the Internal Medicine Residency Program. Dr. Meg Johansson is associate professor here at the University of Maryland School of Nursing, where she is a health services researcher who teaches methodology and statistics in the doctoral programs. Yulan Liang is an associate professor and senior biostatistician at University of Maryland School of Nursing, who's been involved with multiple nursing intervention studies. Karan Burda is a board-certified psychiatric nurse practitioner at the University of Maryland. Catherine Ferneely is an assistant professor here at the University of Maryland whose expertise is addictions treatment and the integration of primary care and behavioral health services, including screening and brief intervention, referral for treatment expert. Naray Han was our research assistant, and you can see a picture at the bottom of Naray and two of our site coordinators, which were Stacy Troutman and Audrey Lupstein. So I wanted to start just by acknowledging the diversity and depth of our team, because without each team member, this work could not have been accomplished. Just to give you some background on the issue, as Shelley said, this substance use is a priority public health issue. Studies in acute care settings have demonstrated that as much as 32% of patients screen positive for high-risk drinking or drug use. According to the Joint Commission, an alarming 1 in 4 admissions are related to alcohol, tobacco, or other drug use. More than 2 million deaths in the United States each year, 1 in 4, is attributable to the use of alcohol, tobacco, or other drugs. Substance use is one of the nation's greatest unmet health care needs in hospitals throughout the United States. Studies link heavy alcohol use, for example, to exacerbation of disease, injury, and death. Nurses have a key role in patient screening for substance use. Comprehensive nursing assessments are conducted on admission to acute care hospitals and always include questions about alcohol, drug, and tobacco use. The screening questions, however, vary and often don't use valid and reliable instruments to screen for risky substance use. For example, a question may be, do you drink alcohol? How much do you drink in a week? Furthermore, referral for additional screening, assessment, or treatments vary. Screening, brief intervention, referral for treatment, SBIRT, has demonstrated efficacy to decrease risky substance use. The United States Preventative Task Force recommends that clinicians provide SBIRT to eligible patients. The level is B level, which means that the United States Preventative Task Force found at least fair evidence that SBIRT improves important health outcomes and concludes that benefits outweigh harms. Behavioral counseling interventions improve intermediate outcomes such as alcohol consumption, heavy drinking episodes, and drinking above the recommended amounts, and may reduce hospital days for adults with risky or hazardous drinking. Substance Abuse and Mental Health Services Administration, SAMHSA, and Health Resources Services Administration, HRSA, Center for Integrated Health Solutions, have issued a brief about SBIRT called Opportunities for Implementation and Points for Further Consideration, citing the potential for SBIRT to reduce healthcare costs, reduce severity of drug and alcohol use, reduce the risk of trauma and injury, and decrease the number who go without treatment. Estimates suggest that improvements in health, as well as cost savings of $3.81 to $5.60 per dollar spent. So not only is it efficacious, but cost-effective. Because of the prevalence, health risk to society, and strong evidence for the effectiveness and efficacy of SBIRT, the Joint Commission introduced SBIRT as a core measure in 2012 for patients who present to hospitals with excessive alcohol use, use of illicit drugs, misuse of prescription drugs, or tobacco use. Adoption of these measures mean that patients admitted to hospitals will be screened for tobacco, alcohol, and substance use, and treatments initiated when indicated. SBIRT has high capacity to improve the quality of patient care. According to the American Hospital Association in 2012, over 35 million adults were discharged from acute care hospitals. Assuming that 1 in 4 patients screen positive for substance use, 8.75 million are admitted and screened positive. If we consider that only 10% of patients with a history of substance use decrease or eliminate use of substances as a result of SBIRT, that could result in improvement in health for 875,000 people nationwide, and that's a low estimate. So SBIRT has the potential to reduce harm, improve healthcare quality, and reduce cost. Nurses have an immediate and sustained presence in the care of patients admitted to hospitals, yet the use of reliable and valid tools to screen patients is low. A hospital admission provides an opportunity to identify patients that use substances and intervene at a time when they are receptive to interventions and follow-up. Because of the high risk for injury associated with substance use, use of SBIRT in healthcare settings can reduce the risk among those who have not yet sought treatment. The purpose of this study was to test 2 approaches for implementing nurse-initiated SBIRT in acute care hospitals. So SBIRT is a comprehensive, integrated approach to the delivery of an early intervention and treatment services for persons at risk for unhealthy substance use. This study focused on the implementation and spread of an evidence-based intervention, SBIRT, by nurses. So this study is aligned with recommendations from the Institute of Medicine report, Improving the Quality of Health Care of Mental Illness and Substance Use Conditions, which issued strong recommendations to coordinate mental health and substance use services with general health care. Our study used a mixed method approach, a cluster randomized trial which included 7 hospitals in the eastern United States. Were used to test these 2 implementation strategies on nurse adoption of SBIRT in acute care hospitals. The 2 implementation strategies compared were SBIRT training, which is standard for health systems when implementing new processes to improve quality of care, to an intervention group, which was SBIRT training plus use of an evidence-based behavioral practice approach. Both groups received site coordinator training, which was SBIRT process and tools and motivational interviewing, a toolkit which included an algorithm, teaching tools, videos, PowerPoints, and a readiness ruler, implementation coaching, a site visit approximately 1 month after the beginning of the intervention, and monthly synchronous web-based meetings. The evidence-based behavioral practice, or EBP approach, incorporated review of the evidence supporting SBIRT through the 5-step process, which is ask, acquire, appraise, apply, analyze, and adjust if needed. Just to give you some background on the evidence-based behavioral practice process used, Dr. Spring and Satterfield and myself, Dr. Spring and Satterfield were co-investigators on this grant, have worked together since 2006 on the Council of Evidence-Based Behavioral Practice. The council was chaired by Dr. Bonnie Spring and was sponsored by a contract through NIH's Office of Behavioral and Social Science Research through the National Library of Medicine. The council includes members from the disciplines of medicine, nursing, psychology, social work, and public health. Our team developed the EBBP model, which is purposefully transdisciplinary to support integrated evidence-based care with resources that include competencies and educational tools, which can be accessed at www.ebbp.org. Competencies in evidence-based practice were developed with input from 24 professional organizations, including the American Psychological Association, American Association of Colleges of Nursing, Association of Schools of Public Health, and Council of Social Work Education. So incorporating evidence and the evidence-based practice process into the implementation of new interventions in other studies have led to higher adoption by healthcare providers. For example, the effectiveness of incorporating evidence-based practices in supporting practice changes has been demonstrated among physicians. Significant improvements to implementation and adoption of evidence-based care were realized after training which included the empiric base for interventions that were known to work. Adherence for research-supported interventions improved significantly, increasing from 49% to 62% after the training. So in this study, 4 hospitals were randomized to the intervention group and 3 randomized to the control group. 2 site coordinators from each hospital attended a 1-day training at University of Maryland, Baltimore. The intervention and the control group attended on 2 different days. Baseline and 6-month measures were collected via nurse survey and medical record review to assess the intervention. Site coordinator interviews were conducted after the study intervention was complete via the telephone. So as you can see from this slide, the bottom line is that results demonstrated that after adjusting for hospital cluster, this study improved screening for unhealthy substance use. In addition, it identified nursing characteristics that were associated with better adoption. So we did not find a difference in the 2 groups. We did find that they improved overall in screening with valid and reliable tools. The target audience for this study included the health system, nurses, and patients. Implementing SBIRT required that we consider healthcare processes, including the work of nurses within healthcare systems, and instruments to quickly screen patients that would not burden the patients or staff and would identify people at risk so that additional screening could be conducted if indicated. A toolkit was provided to each site. To construct the SBIRT toolkit, we worked with experts and clinicians to advise us on the best processes so we could tailor the intervention to the acute care settings. For example, one of the major barriers that nurses report to adopting evidence-based practices is not enough time. So the team sought to use the best method to quickly screen for at-risk alcohol use, for example. So we used the single question screen that's endorsed by the National Institute of Alcohol Abuse and Alcoholism. The first step in screening the patient was to ask this question: how many times in the past year have you had X or more drinks in a day? Where X is 5 for men and 4 for women. This question is 81.8% sensitive and 79.3% specific for the detection of unhealthy alcohol use. So we sought to use these tools that could quickly identify the patient that needed additional counseling advice or referral for treatment. If patients' response were positive to that first screening question, we used one for alcohol and one for drug, a second stage of screening was conducted. We used the Alcohol Use Disorders Identification Test audit tool for screening for alcohol and drug use screening. An assessment for other serious conditions was also conducted. The next step was an assessment of the problem severity and the patient readiness for change. So patients with no or low risk substance use would receive praise and prevention messages, while others with harmful substance use may receive brief counseling with referral to specialty consultation. Nurses discuss the screening results with the patients, assess their patient readiness to quit, and then the advice or counseling was based on that interaction. In addition to the toolkit and the algorithm, strategies were also planned in this study to promote expert implementation. So in addition to the toolkit that I just described, there was also baseline assessment, training, site visit, and the synchronous meetings were included as part of the implementation strategy. To assess the implementation fidelity, we also assessed training outcomes by return demonstration after training was completed for site coordinators, which the site coordinators then went into their practice setting after completing the training. Also were to assess the nurses' competencies in completing SBIRT. To assess the organizational characteristics, we used a baseline assessment survey as well as nurse survey that included nurse attributes, change-related commitment survey, Janssen 2004, organizational change recipients belief scale, or Medicus 2007, and an evidence-based practice attitude survey, which is Aaron's 2004. To assess the intervention effect, we conducted a medical record review at baseline and 6 months after the intervention. A random sample of 60 patient medical records were reviewed at each time point at each site to collect data on SBIRT use. 416 records were reviewed at baseline and 418 at 6 months. You can see that the Cochran-Mantell-Hansel analysis was applied in order to test the association between pre-post responses for group and hospital effect, and there were significant improvements in screening with valid and reliable tools. So as I mentioned, there were not differences between the groups, but pre-test, post-test, there were improvements between baseline and 6 months for both groups. In addition to testing the intervention effect, we also used approaches to assess implementation of SBIRT by nurses. And in this result, we had conducted a randomly selected day. So on 5 days toward the end of the intervention period, we randomly selected days and assessed nurses whether or not the admitting nurse had implemented the SBIRT protocol. 83 surveys from 6 sites were returned, and you can see it was a very positive response. So over 3/4 of the nurses that were surveyed in this randomly selected days reported that they had screened their last patient using a validated instrument. And of those, about 17% reported that their patients screened positive for unhealthy substance or drug or alcohol use, and about 10% screened positive for high-risk use. And of those eligible, about 9% of all the patients received a brief intervention. So those at high risk, so there were 8 patients at high risk, and 7 patients received the brief intervention as reported on these randomly selected days. Now, this result is higher than we saw on the medical record review. We collected medical record data at baseline and 6 months. At 6 months, on these randomly selected records, we saw about 52% screening with valid tools for drug use and about 58% reported for alcohol use. But you can see these are very positive results. Furthermore, we attempted to determine how long it took to screen and conduct the brief intervention. So 75 nurses reported that there was a mean of 3.5 minutes for screening, which is pretty good, and that the brief intervention took them about 2.2 minutes with a standard deviation about 5 minutes. So, as you remember, nurses often report that time as one of the worst issues or barriers to implementing evidence-based practices. So the time, I think, is an encouraging result so that it is achievable. I also want to note that in the assessment of the implementation, there were a whole group of other instruments that were used to assess the implementation. So there was an implementation checklist that checked the steps required to implement SBIRT. There were steps to verify that the training was conducted and the local nurses were trained. The booster was conducted 1 month after the initial training as specified in the protocol. The implementation barriers were assessed via survey and a post-intervention interview with the site coordinators. And there was also a survey about implementation barriers. So when we assessed which organization improved most in terms of valid and reliable screening, we saw the following characteristics. Those that were most successful tended to train more nurses. That's about 21 versus 14. 3/4 of those that were most successful reported that they completed a booster versus 1 out of 3 that completed a booster on their unit. The most successful 3/4 reported that they revised patient forms or electronic medical record versus those that were not as successful with the program. The fidelity, the nurse fidelity, the nurses and sites that did better, according to the medical record review, also had higher levels of validated screening on their self-report, 81% versus 65%. In terms of the barriers, the biggest barriers reported in each group were the competing priorities of implementing SBIRT, patients experiencing symptoms like pain. The interviews also made it very clear that time and competing priorities were an issue. Those that had lower improvements demonstrated or talked about on their interviews that there were significant organizational initiatives that were happening at the same time the protocol was being implemented, such as implementing an electronic medical record or additional training or competencies that were being conducted at the same time. All of the sites reported that the tools that were provided were extremely helpful. So when we think about the impact of this study, more patients were screened with validated tools for alcohol and drug use, which was a very positive result. Not only that, nurses can and they do implement the protocol to screen patients and conduct a brief intervention when they receive the training. 4 of the 7 sites will continue with the SBIRT protocol and spread the intervention throughout their organization. This SBIRT protocol also changed the general knowledge about alcohol use and drug screening within these organizations and demonstrated areas where the best adoption occurred. So in terms of what's next for our team, first of all, we know that our toolkit works and it's implementable. So our intent is to spread the SBIRT practices to other acute care hospitals through dissemination of our training materials, to provide some of those best practices in the adoption of SBIRT, such as the changes to the electronic medical record, provision of the toolkit, and the algorithm. Our intent also is to conduct a follow-up study to test additional successful SBIRT strategies, because we know that the real need within acute care organization is to spread those strategies that we know work for patients to improve care and outcomes, that can really enhance the evidence-based processes that nurses and the interprofessional team implement, one of which is SBIRT, and that we need to study the strategies that are best and most successful in spreading these efficacious treatments such as SBIRT. So in conclusion, our study found that both groups did as well, that SBIRT is a evidence-based practice that can be conducted by nurses. The time it takes to implement it is not as long as one anticipated at the beginning, and that there were broad improvements in many of these sites, and we were able to identify the characteristics of those sites that were most successful. Thank you.
I'd like to thank you, Robin, and your team for your excellent work to advance and improve the quality of care for those with excessive substance use. And I also want to congratulate you and your team for demonstrating that it is possible to successfully integrate behavioral health assessments in a primary care setting. There have been many requests to do those, to make those types of efforts, and you have successfully done so.
Well, thank you.
I also want to ask this question about nurse-led teams, and why is it important to emphasize the use of nurse-led teams to enhance the effectiveness of the use of SBIRT?
Well, particularly in acute care systems, the nurse has an immediate presence at the bedside and acts as an important member of the interprofessional team in the coordination of care. In addition, it's the nurse that does the preliminary assessment, and for SBIRT in particular, they have the opportunity to intervene at a point in time that's a teachable moment. If, in fact, they can use valid and reliable, quick screening tools and identify the people at risk, they can spend those precious moments that they have on the patients that need it most. When patients are identified that need additional counseling, additional advice, or additional treatment, they can then refer them to services within the organization so they can actually connect them to the right systems of care so that when patients are discharged, they can link them to other treatment services in primary care. So it really is the immediacy, the information that nurses achieve in their preliminary assessment of patients, their interaction, the trusting relationship, and their ability to screen quickly, intervene quickly, and get the patients the treatment that they need within the acute care setting so that treatment can follow after the patient is discharged.
Okay, thank you. Is it possible to build upon this research in a community-based setting?
Absolutely. So SBIRT, most of the studies that demonstrate the efficacy of SBIRT have been in the primary care setting. So it has good efficacy already. So the new change was in this study implementing it in the acute care setting. So absolutely there were many, many successful SBIRT interventions in emergency departments, in community settings. It can be spread widely. It is a protocol that works to reduce alcohol, drug use, and should be implemented in community settings, and it has demonstrated spread in those areas as well. So nurses also in the community setting could be a leverage for promoting SBIRT use as well.
Great. We now have an opportunity for our attendees to ask questions.
Yes, hi. It's Randy Krakauer. Thank you. I appreciate the opportunity to hear this, and thank you very much for your work and presenting your work. A couple questions, if I may. First of all, can you give us some more detail about the comparability of the populations that you were looking at here? You indicate this was originally used in a community setting, and now you're validating this in an acute inpatient setting. You looked at several different hospitals, and you have a selected and non-selected population. How comparable, or what are the comparability factors between these various populations?
So when we think about the populations, we did not collect patient information. So this study was focused on implementation by nurses as opposed to efficacy for patients. So we didn't collect patient population information or patient information. We didn't collect any patient information at all. We only collected the medical record items that related to SBIRT without any description of patient information. In terms of the community hospitals, these community hospitals that were used are typical community hospitals. They varied in size. They varied in location. We didn't adjust any of these analysis for hospital type. We did ask that the intervention was focused on medical surgical units, but it is true that these medical surgical units could have different characteristics of patients. So in terms of the representative of the patient population served, we did not collect that information. What we were interested in is, could this be implemented in these acute care hospitals? The Joint Commission measure is now available in just this year in 2012. And could it be implemented by nurses? Could nurses make a significant impact on screening patients and getting them the treatment they deserve and need? But we did not collect any additional population. So in fact, that is one of our projected next steps, is to do some more work and to propose another study about looking at the system science or the system changes around implementation of SBIRT within organizations. So and we also know that we would like to, in our next study, follow patients into the community setting to determine if, in fact, the efficacy of SBIRT from acute care to discharge home shows the same positive responses as the community setting and in primary care.
Yeah, that would be a great follow-up. Thank you. And I think you've done a very good job making the case that you set out to make. Are you looking to screen every admission that's for which the physical condition makes it appropriate, or is there a particular pre-screening? Is there a particular population that you would look to screen, and another population that you might not want to screen amongst acute inpatient admissions?
Well, I'm going to answer that in a couple ways. First of all, with the incidence of substance use for patients in acute care hospital, we were able to demonstrate that using that single screening question could be implemented. So there would really be no reason not to screen everybody with that single screening question. Now, there are other criteria for harmful use of alcohol and drugs and other longer screening and assessment tools. But our target was to implement a protocol that is implementable, that people could use. So using these single questions screened out the people at risk. So we were able to help nurses very quickly get to the people that needed the help most. So in other settings, perhaps some of these longer assessment tools are appropriate, but in the acute care setting when patients are admitted, we were trying to figure out a way to help nurses have a timely and accurate assessment for who needs it, and then drill down in the second stage to use screening tools that would give them more information, and then either they would conduct the brief advice or counseling, but they would also recognize the people that needed treatment. And to get a professional that could do a comprehensive assessment and a treatment plan with a patient and get them to those people. So your first question about screening, with the incidence, every patient should be screened. But certainly identifying the risk and getting the right people to the right service would be the important priority for nurses and for the interprofessional team in acute care hospitals.
Thank you. One more is, do you think the emergency room might also represent an opportunity?
Absolutely, and efficacy in emergency departments has already been demonstrated in a number of studies. So absolutely, this is such a prevalent problem that healthcare services need to have comprehensive approaches to screening for these kinds of harmful effects of substance use. So wherever we contact a patient, brief screening should be conducted. And if providers don't have the training they need, there should be referrals to providers that can provide a more comprehensive assessment and treatment plan.
Thank you very much.
Are there additional questions?
And as a reminder, if you would like to ask a question over the phone lines, please press star 1.
I have a couple of questions that were submitted online. Two were actually submitted, Robin, related to the differences between the two groups, the SBART training alone versus training plus use of evidence-based training. And the punchline question, I guess, is why do you think the increased intensity of the EBP group didn't yield an increased effect?
Well, and we have to think about that. And part of it may be that when we did the interviews to talk to sites about what worked and what didn't work, so in terms of the intervention group, they got lots of tools, but the real strategy that was being implemented was SBART, and both groups got lots of good tools. And when we did the interviews, they said the tools were great. The tools really worked. The algorithm worked. The training worked. So in terms of moving forward from the point of the training and moving forward 6 months later, so the interventions groups went back to their organizations. They trained their nurses using, and some of them reported that they used their own evidence-based practice model and tools, and which was fine. It was about evidence-based practice. But our intervention asked that a booster for SBART was conducted 1 month later. So in terms of following up and asking them, did all of your nurses use the evidence-based behavioral practice training materials? Did they all access the introductory web-based training tool? We didn't demand that. We didn't collect that. We made that part of the training. But what sites reported was really focusing similarly, both control and intervention groups, similarly on SBART. So they appreciate the evidence-based tools, but the real intervention seemed to be more associated with these tools that they had provided to them, and including the baseline assessment, the different checklists that they had for training. They weren't different between the groups. So we heard it was really that toolkit that helped. So that's what I would hypothesize, that it is really the tools that helped, as opposed to, so they had one contact with the intervention being taught from the evidence-based practice framework. We did not continue the intervention. The group, the study team did not continue the intervention, or there weren't interventions that we gave them another booster for implementation of evidence-based practices. Our boosters were more related to use of SBART and how implementation was going, similar in both the intervention and the control group.
Robin, I have another 2 questions that are sort of similar. The first one was, you noted that 77% of nurses used the validated instrument. Did you have a sense of why others might not have? And the next question that's similar is, could you elaborate on the nurses' reactions to using SBIRT, and did you conduct qualitative interviews with them?
We did. So the difference between the Heather, the difference between the two groups is the control group received SBIRT training, which is very similar to any implementation in a quality improvement initiative. So, the PowerPoints, the training, the tools, the return demonstration materials. The intervention group, the training focused less on, anatomy and physiology of substance use, and more on the evidence and the articles that support SBIRT use, the study results about how implementation occurred. So the training was different for the intervention group, and the training tools that were provided included the evidence related to SBIRT use and implementation of SBIRT in acute care settings, with the intent that the training that the intervention group received also would be used for the training in the site. So that's the question about the difference between the two groups. And when you think about the increased intensity group didn't yield increased effort or increased effect, I think it's sort of the same answer as the question that Randy asked. It diffused, I think, over time. So the questions people were asking on the calls were about SBIRT. It wasn't necessarily about evidence-based practice and implementing evidence-based practice. So it became more about SBIRT than it did about implementation of evidence-based practices. Did I get all of your questions, Heather?
I think so. I have another one.
Okay.
Can you elaborate on the characteristics of hospitals that are spreading versus those that are not?
The characteristics of those that are spreading, you mean in terms of bed size, what they were like? I can tell you that those that were spreading were actually the ones that did better. So all of the organizational characteristics that I expressed for people that did better are related to people that also said that they were going to spread, or that they were either going to spread the whole protocol or pieces of the protocol, or they were going to do additional training on motivational interviewing. So it was the same characteristics as those that did better. So let me go back to...
So this is Mary, and this was actually my question, but I was wondering if, in terms of elaboration, if are there characteristics associated with, where there's strong champions in these facilities? And maybe you didn't focus on that per se, but were there things that helped kind of create an environment to make them want to do this? So I was wondering if you had any thoughts on that.
Yes, I have thoughts now in terms of doing a qualitative analysis of the interviews, but I'm going to speak from the heart and the experience. But there were a number of sites, and those sites that did better had very engaged champions. They worked with the units to foster the adoption. There was good communication and interaction. There was good relationships with the nurses on the unit. So that would be my sense. In terms of how many nurses were involved, I think it was a little bit of a surprise to me that those that did better actually trained more nurses. We were thinking that those that trained less nurses sort of would have more control over the protocol, but actually when you look at those that did better, they tended to train more nurses too. So yes, I would say that the champion was important. The opportunities for the champion, the site coordinators, to really tailor this intervention to their own practice setting, to embed the SBIRT screening into their medical records was another important area where people excelled. So those that really adopted it within the system did better. So champions, system thinking, making it easy for the nurses seemed to result in better adoption.
Great. Thanks.
Robin, a follow-up question that was just submitted. Do you think that just committing to participate in an improvement project has an effect in and of itself?
I do believe that people that are going to volunteer for these kinds of things may have a higher propensity of commitment. However, I would say when you think of commitment, so the first level of commitment for a project like this is at the nurse executive level. And the second level of commitment comes from the site coordinators that attend the training or the team within these organizations. So, the organization commitment from the executive, depending on what the relationship is with the executive, how much the executive fosters the implementation of these practices, how much they follow up with how things are doing, might also make a difference. So that's why I say, at one level, just committing from the nurse executive level, maybe, but it's got to be commitment from the folks on the ground, the site coordinator level, really to have an effect. Now, the site coordinators all willingly came to training. But when you really think about it, there could be site coordinators that weren't as invested in the implementation. They were happy to participate in the study, but there certainly were some with a passion for SBIRT, had done some work, had problems in their organization, and were working on like an alcohol withdrawal protocol. They had worked on implementing some alcohol screening. So this was very enticing to them because it was helping them with a problem that was important to them. So there's probably a variance in sort of the site coordinators' commitment. And then when you think about the next level, the nurses' commitment, we're asking them to do something additional to what they're doing in a very busy day anyway. So I think we have to think of all of those levels. It's not just a matter of committing, but there's a level of commitment and excitement and engagement and willingness and readiness to implement and get over those bumps of implementation that's going to make a difference, probably not just the commitment itself.
And the last question that I have submitted, is the toolkit publicly available?
We have not made it publicly available. We have talked about where it would be published. We have talked about dissemination of the toolkit through a number of media, but we have not selected what that media will be. So no, it's not yet publicly available, but as soon as we can, it will be. We're still working on getting our publications together and submitted.
Great. Well, those are all the questions that I have submitted online. And do we have any queued on the phone?
We do. We'll take our next question.
Hi, Robin. This is Linda Flynn. Congratulations. This is great. And actually, my question was answered.
Oh, thanks, Linda. Very good. Well, and I would say, I have to say on behalf of my team, how grateful we are for the opportunities provided through the Interdisciplinary Nursing Quality Research Initiative and Robert Wood Johnson Foundation to conduct this work. And certainly without this support, we wouldn't have been able to test these implementation strategies. And we so much appreciate the opportunity and the graciousness of the partnerships with the sites and the nurses that we worked with to create these excellent results.
So this is Mary, and that's a great segue for me to say thank you to you and your team for really capitalizing on this opportunity. What important, significant work that you've focused on, and really important findings to help in a very, very challenging area to figure out how great interventions that may work in one context can be applied in other contexts to maximize on the important opportunities nurses and other team members have to really impact the lives of people. So we are very, very grateful. You did, an outstanding presentation, Robin, and I think I'm sure have stimulated and set the bar very, very high now for the subsequent webinars. So I want to thank you on behalf of our entire program, and Shelley, I want to thank you for guiding us through this conversation, Heather for organizing all, and so we'll look forward to the next series of the webinars, and Robin, you and your team can now sit back and relax and enjoy what you're going to hear from your colleagues. Thanks so much for your work.
Thank you.
And thank you, everybody, for participating on this call. It is has been taped and will be available as a taped session on our INQRI website. And again, you'll find, Heather will be doing email blasts, but you'll find information on the next series of webinars that will follow this that will describe the work of the teams funded in 2010 who are now coming to the end of that part of their journey. All right. Heather, anything else at your end?
No, I think that's all, except that look for the recording. It will probably be up sometime next week, also on www.inqri.org. Thank you so much.
Great. Thanks, everybody.